had a stronger objective response rate than bevacizumab based on prior data. There was no statistically significant difference in response rate. So the primary endpoint of the study was negative. An important secondary endpoint of the study, progression-free survival, again negative. As expected, progression-free survival in the range of about 10 months, which we've seen more or less for the last 10 years. This is where we are right now in progression-free survival in first-line therapy. So no difference, absolutely no difference. Now, the first analysis we saw about overall survival was a surprise to everyone because we saw a later split of the curves than covered by first-line therapy with a hazard ratio of 0.77, a 23% reduction of death events on the study. Now, this part here is protected by randomization, meaning this is here the progression-free survival curve, progression-free survival time, and you see that the curve split later when fewer patients than initially enrolled are on the study. That's just a matter of how these studies were conducted. So the question was, why did this happen? What could be reasons why we did see a difference in overall survival with exactly the same progression-free survival? This was actually unprecedented in colorectal cancer. We've seen some of these issues, progression-free survival and overall survival, not going in line in immunotherapy trials, for instance, with ipilimumab in melanoma, but really not with cytotoxic chemotherapy, even with biologics in colorectal cancer. So could there be an imbalance in post-progression therapy? And I still believe we have not clearly sorted this out, because it's not just a matter of how patients or the frequency with which patients were treated, but also how long they were treated. As you heard, duration of therapy matters, particularly for anti-VEGF agents. Could it be that there is an optimal sequence that EGF-receptor antibodies should be used first, and then VEGF antagonists work better in second-line therapy? This is still a question that I have. We probably need to address this in animal models. And then the other point is, could there be a small population that drives the difference in the tail of the curve that's highly sensitive to EGF-receptor antibody effects? And I think this is one of the more likely effects apart from imbalance in post-progression therapy. Now, the investigators, the FIRE3 investigators, did an amazing job in embracing the new RAS mutation analysis data within 2 months and actually came up with a comprehensive RAS analysis from ASCO to ESMO 2013 and identified, as expected, about 15% of additional RAS mutations. But they now look at the data, and this is published in Lancet Oncology just this year. Now the separation was a little bit larger with a hazard ratio of 0.7. Fewer patients now, because not everyone was able to have a RAS analysis and has RAS wild-type tumors. But the difference here now was quite surprisingly large for more than 7 months. So this is something which we have to reckon with, and we really needed a confirmatory study, a larger study with an appropriate endpoint overall survival to see, is this a real result, or is this based on some factors which are not under our control in the study? And this study was actually already conducted, and it was presented, the confirmatory study. Actually, I wouldn't call it confirmatory, because the study was actually initiated before FIRE3. It took longer to accrue, but it was eventually a larger study, almost twice as large as FIRE3, conducted in the United States in the intergroup without commercial support, really, or independent from commercial support from companies. And you can see here the chemotherapy backbone was up to the investigator, 70% FOLFOX, 30% FOLFIRI, cetuximab versus bevacizumab, with a primary endpoint of overall survival. The study has been presented at the plenary session of ASCO this year, and then updated at ESMO, and there's a lot of data that are still outstanding. We'll see a flood of data come in the next meetings, and the more data we analyze. So as expected, no difference in progression-free survival, very similar to FIRE3. Now in the overall survival analysis for both treatments, FOLFOX and FOLFIRI combined, this is the primary endpoint of the study, no difference, and we see about 30 months median survival, which is nice, and it's actually longer than the study actually expected. So no difference at all. Contradicting the data from FIRE3 with a study powered for overall survival. This is the primary endpoint. Now you can slice and dice, and now you tease out the FOLFOX and the FOLFIRI treated patients. No difference, if at all. If you really want to look at a trend, FOLFOX and cetuximab seem to be actually quite okay, and this is the reason why this combination actually made it into NCCN guidelines as a potential option. And FOLFIRI, bevacizumab actually did very well here. Long median overall survival here of 33 months. So this is clearly a very good prognosis and good treatment for patients. Now, the investigators also did the all-RAS analysis, comprehensive analysis presented by Dr. Heinz Lenz, who was here at this meeting at ESMO in Madrid, and there was another 15% as expected new additional RAS mutations. Now, what's the impact of the refined patient population analysis with all RAS wild-type or extended RAS wild-type on outcomes? No difference, no changes, virtually no difference in progression-free survival, no difference, no statistically significant difference in overall survival. And you can break it down in FOLFOX and FOLFIRI, in the FOLFOX progression-free survival, FOLFIRI progression-free survival, and in overall survival, FOLFOX and FOLFIRI, absolutely no difference in outcome. So this is more or less what we all expected. When I was around in the United States when the trial was designed, and we actually said, there's not going to be a difference in overall survival for reasons that Dr. Sargent actually mentioned. We can impact probably the first 10 months of therapy, that's covered by randomization, but we know that second, third, and fourth, and whatever line of therapy, which will influence outcome in terms of overall survival, will dilute any effect we might see in first-line therapy. So this is exactly what we expected. And I would actually say that this is 8405, and these are the FOLFIRI treated patients in the RAS wild-type group. You can see here no difference in outcome in overall survival. Now we superimpose the FIRE3 data. And this is the FOLFIRI cetuximab arm, which is clearly very much in line with the data from the 8405. But the FOLFIRI bevacizumab arm is the only outlier here. The question is, could the duration of therapy in this German-Austrian trial be, let's say, not appropriate, too short to really cover the full extent of the VEGF inhibition, which we know is important to really optimize outcomes for patients. So this is where we are. The investigators from both groups, FIRE and 8405, have agreed to pool their data. There will be a lot of analysis coming out. We will figure out what's going on here. I'm pretty sure this is an academic endeavor which will help us identify is there an appropriate and best treatment sequence for patients with metastatic colorectal cancer. So right now, when you talk about conclusions from what we've seen, each of the antibody, we know cetuximab and panitumumab are interchangeable. We need to go beyond KRAS exon 2. RAS wild-type testing, I think, is mandated. I believe FIRE3D and 405 are more similar than different. The one outlier is the bevacizumab arm in FIRE3. And we have treatment options, and I think we all now embrace this strategically for our patients. Now let me give a little bit more idea about where I think we need to go and we should go. And I'll give you at the end my top 5 list of new drugs beyond what you've seen today in colorectal cancer. This goes kind of along the lines of what Dan talked about, novel approaches in drug development to colorectal cancer. You've seen this analysis here of the Cancer Genome Atlas Network. We have identified signal transduction pathways, mutational pathways in colorectal cancer, which are activated. And we have identified a group of patients, the so-called hypermutated patients, which have thousands and thousands of mutations sometimes in their tumors, based on the fact that they are mismatched repair deficient, MSI high, so they are microcell-like unstable tumors. And those tumors are about 15% of all patients with colorectal cancer. I will skip over some of the data here because I'm sure that Dr. Lenz talked about it, but I want to highlight my top 5 new drugs, new treatment strategies for colorectal cancer. Number 1, I think we are on the verge of getting better treatment options for BRAF mutated tumors beyond FOLFOXIRI bevacizumab, which I think is probably the best treatment we have right now. We're combining BRAF inhibitors and the EGFR inhibitors with MEK inhibitors. That is a strategy which is currently tested in phase 2 randomized trials, and I think it's very interesting. PD-1, PD-L1 antibodies can play a role in colorectal cancer in these so-called hypermutated tumors. These tumors are very deranged. They have an antigen profile which can be recognized by the immune system. So I believe this is something where we need to really focus our attention. MET inhibitors and MET amplified tumors, less than 5% of colorectal cancers. HER2 is overexpressed in about 4 or 5% of colorectal cancers. And there are very few patients here that have ALK and ROS mutations or fusion proteins, where I think we have established agents in other diseases like lung cancer, which we can utilize. These are about 15 to 20% of patients where we will see advances in the very near future. So I want to finish by giving you a treatment algorithm which is published, which was published in Oncology this year. The first treatment, the first step in the management of colorectal cancer, metastatic colorectal cancer, molecular testing currently for RAS and BRAF. If you have any RAS mutation, you do not use EGFR receptor antibodies. If you have all RAS wild type, you can use EGFR receptor antibodies, but you can also look at a prolonged duration of VEGF inhibition followed by EGFR receptor antibody and regorafenib. And I think BRAF mutant tumors, they need a different approach. Outside of a clinical trial, FOLFOXIRI bevacizumab is clearly right now the most established treatment for patients with performance status. Thank you very much.
The next speaker of the Francois Lacan. Professor Francois Lacan, since 1984, he was a surgeon at University Hospital, Tenon, AP, and Hopkins, Paris, and now he's also a professor. And today we are talking about the liver metastasis of colorectal cancer. Which treatment? Professor Lacan, please.
Thank you. My speech of this afternoon will be more surgical than this morning. Actually, will be multidisciplinary speech. So, as you know, colorectal cancer is the third cause of death. Third cause of death in the Western countries. As you can see here, incidence per year, and incidence deaths per year. And actually, half of the patients who have colorectal cancer will have at some time liver metastasis. And 60 to 70% of them will die from the liver metastasis. So it's an important challenge, and it poses a multidisciplinary strategy. But those are mixed curves from several publications, and as you can see, obviously when we were performing no treatment, bad. In the middle, you have the only chemotherapy treatments, and here, when some resection is done. And since several years, the most important progress has been made by introducing chemo and biochemotherapies, which improved the result of the surgery associated with progress in radiology, and also surgical strategy, which I will point out. Those are the progress we made since 1994, since nowadays, and you see that in the early 90s, the most important series was the French one, and you see that the survival was roughly a quarter of the patient. And nowadays, the things are much better. You see that roughly 50% of the patient will survive for 5 years. What are the explanations of these improvements? First of all, and it's important, improvement in patient selection by improvement in CT scan and CT scan by diffusion, MRI, PET scan, and calculation of the volumetry. and also laparoscopy, which is used more and which can help to select patients. Then improvement in operative and perioperative techniques, which lead for R0 resection in much more patients. In a certain sense, more combativeness in the recurrence of the liver metastasis by repeated hepatectomy, second and even third hepatectomy, and less hepatectomy mortality. The third one is improvement, as has been stressed by the two previous speaker, improvement in drug efficacy, and the new is more appropriate. Let's see some example of the improvement in patient selection. You see, this is a standard CT scan. So on this, you can see only one liver metastasis, and which could be operated on straight away. Actually, with a fluorodeoxyribonucleic PET scan, you see that actually there are different metastases, iliac nodes and hilar nodes, and with the mixed PT and CT scans, you can see very well those metastases. Here it's an interesting study comparing the studies before this improvement in radiology and after, and with all these means that we have now. This is the result of overall survival now after this improvement in radiology, and those are the study before. So in the past, the number, the size, the situation of lesions, the margin, the absence of extrahepatic disease, necessity of no extrahepatic disease, and surgery was the only tool. Nowadays, chemosensitivity, as already said, the possibility to make several resections or even a radiofrequency activation of any visible, quite almost any visible metastasis, the enhancement of resectability, and do we need a hepatic specified surgery? It's what we think in France. How much must be left for to try an hepatectomy, and how can we enhance the hypertrophy of the liver, the remnant liver after hepatectomy? Could be ideated surgery in 2 steps or more, and finally the decision is multidisciplinary during a meeting, and also the patient and the general practitioner participate to the decision. Let's see how we can grade the different sort of liver metastases. Either they are easily resectable because less than 4 metastases and no extrahepatic disease, and we can predict left or right hepatectomy or less, because less than 4 segments are concerned, and the remaining liver will be more than 40%. This is not a problem. I mean, every people in the world would operate. At the other end of the span, the grade 3 is clearly non-resectable, because at least 2nd segments are involved. The remaining liver will be less than 25%, and there are no 2 adjacent segments which will be left after the resection. The interesting population is the grade 2 population, because it's possibly resectable, borderline, by often an extensive resection, even more than 5 segments, and the remaining liver will be somewhere between 20 and 40%. And this is actually the more important population where we, not in number, but where we can have some improvement. Well, we have to do first compute what will be the ratio between the future remaining liver and the total liver. And the route that I just showed on the previous slide depends what is the validity of the liver which will remain. Is it an healthy liver? And okay, it's the previous slide. If the liver remaining is somewhere pathological, fibrotic, I mean things are sliding. This is an interesting publication because it stated what are the main reasons for non-resection in patients, for the patients. Few patients were not resected because the liver capital remaining was too low, less than 5%, because the number of metastases, 14%, because the location of the metastasis in some places on the liver which were dangerous, and for the size of the metastasis for the most of the patients. So the improvement has been of two nature. The portal embolization of ligature of one of the right branch of portal vein, and the improvement in chemotherapy, you see, which can have some interest in the number and in the size of metastasis. Obviously, contribution of chemotherapy is important. This is an example, and this is the response rate with the different regimens. But we have already spoken about this with Dr. Sargent and Rothy. And you see that some response come from roughly 40% now to almost 80%. And this is interesting for the surgeons. Why? Because there is a real correlation when the study selected the patients, a very high correlation between the response rate and the resection rate in those patients. So, if we make a summary of what I just said, when you have a liver metastasis, 15% are initially resectable because they belong to grade 1 category. And it has been shown, I will show in the next slide, that the surgery must be sandwiched between two series of chemotherapy cures. The other ones, the other 85% one, are initially unresectable, but because of downsizing of chemotherapy, some of them, 10 to 20%, become resectable. And the question is, what are the surgical strategy? Because it depends on a lot of variables. This is how we can compute the future remaining liver by imaging. And this is a portal embolization. And as you see, the portal embolization, this is a scan before the portal embolization, and you see that the tumor is quite large and would oblige to make a right appendectomy. But after the cure, the tumor has, after the portal embolization, the tumor has shrunk and the right lobe has shrunk. And so, in the same time, meanwhile, the left lobe has increased in size. And you see that even if you have to left only the left lobes, it represents 23%. And if the remaining liver is healthy, there's no problem. But you could even leave the whole left liver. Those are the series, and with not only 28% of survival. Those are only the resected series. You see that now it's around 50% resection and survival. Grade 1, the ERTC trial showed that the perioperative chemotherapy was better than surgery alone, and that chemotherapy just adjuvant. For the grade 2 and 3, multiple and myeloma liver metastasis, it depends, but it has already been stated just previously, so I will go further. So this it was before chemotherapy. This is after the chemotherapy. Do we need to make a right hepatectomy with a metastasis resection, or do we need to treat this one by RFA? We don't really have the answer. It depends, because we have so many possibility now, and mainly the radiofrequency, that it's really a strategical matter. Can we do in a one-step surgery after right portal embolization and an interval chemotherapy? This is the result with an increased volume of 30%. Or we can even do a two-step surgery with, during the first step, radiofrequency of the left liver metastasis. Oh no, this is metastasectomy, I'm sorry, and right portal vein ligation. And the second step, you just, after 4 to 12 weeks of chemotherapy, you just make the right hepatectomy. So this is another example of this two-step surgery. This is after ligation and removed of the segment 4 metastasis, and this is the remaining left lobes after the second step. These are other examples. And the strategy might be very multiple. So the problem is that chemotherapy induces liver toxicity. And it has been described two syndromes, the SOS syndrome with the blue liver and the yellow liver with steatohepatitis. And so, which is very important, is to know that because of this publication, we have to be very careful that after 6 cycles of chemotherapy, the morbidity of the surgery increased a lot, and so we have to stop at the right time. So, in conclusion, the multidisciplinarity is the most important. The grade 1 is not a problem. Grade 2, I told you what were the possible strategy. But so, if you want to operate after an intermediate chemotherapy, as soon as 2 or 3 cycles, you have to think about the future and to reevaluate your surgery. Operate before hepatotoxicity in grade 2. Non-tumoral biopsy might be interesting to know what will be the status of the remnant liver. Do not operate patients with disease in progression, and portal embolization and CT possible without risk on liver regeneration. I thank you for your attention.
The next speaker will be Zhong Zhiyuan. Right now he is attending doctor also in the division of hematology and cardiology in the Zhanghua Christian Hospital, also the attendant director of the blood bank. Today he will have a talk, and the first-line treatment for metastatic colorectal cancer, maximize clinical outcomes through maintenance and therapy. Dr. Zhong, please.
Dear everyone, it's my honor to be here. I'd like to share my experience to care our patients. I focus on how to maximize the clinical outcomes through maintaining the salvage. As we know, in the past, patients just accept best supportive just can achieve 6 months. In 5 years, the patient can achieve 12 years overall survival. After chemotherapy combination, we can care our patient until up to years. But recently, with selection like RAS or KRAS selection, patient uses spatial combination like cetuximab plus FOLFIRI, like FOLFIRI can achieve up to 33 months. And trial data show when combined with Beva plus FOLFIRI can achieve up to 41 months. But when back to real world chemotherapy usage pattern in the US, in the States, most patients accept oxaliplatin and chemotherapy alone. So we can see in real world it's quite difficult to achieve like clinical trial result. We can look in CLGB, overall survival use the FOLFOX plus the Avastin protocol just achieves 26 months. It's the lowest overall survival actually. All oxaliplatin combination fail to improve overall survival, including 5-FU combination, bevacizumab combination like 1696, and the cetuximab combination with oxaliplatin like COIN-TRI, Nordic trial, OPUS, and the new OPEC. All trial cannot achieve any survival benefit when oxaliplatin used the first line. It's nearly a rule. All fail, but why? We can see the neuromuscular persistence is a big problem. Another issue, possible oxaliplatin can activate multiple drugs resistance or induce pan-drug resistance, like antibiotics. Of course, we know there are many historical differences between Taiwan and the US. In the 5-year era, Taiwan started always use the infusion protocol, but in the States, doctor use the bonus, means mail clinics, like Professor Ezra said, but it's quite difficult to use the 5 days bonus. What you can induce the bonus patient and the GI toxicity. And irinotecan, we initially use the combined with 5-AU weekly or bi-weekly use the FOLFIRI. But in the States, we almost know the IVL is popular in US. And oxaliplatin now we use a salvage, but most patients in States use the FOLFIRI first line. So that's the problem in the trials. Illusion 5U accepted until 2004 in US. And the oxaliplatin proves until 2004. And the FOLFIRI backbone as the first line in US even after 2004, which the best first line therapy. FOLFIRI or FOLFIRI is better or not, but it's quite different in Taiwan and the US. Some scholars say they cannot see when combined with biologic therapy can achieve survival benefits like number 1696 and the Cohen trial. These two trials very biggest prospect trial. So some also thought that the effect of biologic therapy. So we know N9701 is the most important key issue to change the protocol used in the States. But actually, we see Avero is inferior, but actually Avero against Professor Gross's role. At that time, Avero used the 5U bonus, but far faster 5U is infusion. And second-line chemotherapy possible can contribute to overall survival. Outside protein was readily available, but immunotican was not readily available at that time.